Hi everybody. Today we will be trying to discuss something about the choice of pneumococcal conjugate vaccine. This topic has become important because of the entry of a new pneumococcal conjugate vaccine which has changed the game at the ground level, that is Pneumococcal from Serum Institute of India. I will not be discussing about the pneumococcal polysaccharide vaccine and will be concentrating on the three vaccines which are available in the Indian market now. We will be looking at 5 clinical points. As is often the case, we will not be I will not be telling A to Z of pneumococcal conjugate vaccine, but we'll be trying to answer 5 critical questions which I feel critical matters, which I find impinges on our practice directly. The first question we will try to answer in some depth is PCV equally efficacious against pneumonia, otitis media as in invasive pneumococcal disease like meningitis or septicemia in children? This is important for us to understand because some pediatricians even now have some doubts whether this PCV is required as a routine. This is partially contributed because initially the IAP promoted pneumococcal vaccine as an optional vaccine, in spite of the WHO endorsing it as an absolutely required vaccination. But we will be looking whether it is effective really in the commonest conditions like pneumonia and otitis media also. Number two, we would be, this is a very important thing. The Gavi, which funds the national programs about 2 or 3 years and then leaves it to them to continue with it, endorses all the three vaccines. In fact, they fund all the three vaccines. That is PCV13, which is Prevenar, which is manufactured by Pfizer, PCV10, which is Synflorix, is manufactured by GSK, and now 10-valent PCB, which is Pneumococcal by the Serum Institute. Now, when WHO also puts them in this, endorses all of them, does it mean that all of them have the same efficacy and impact on pneumococcal disease? Or is it a political game that WHO and Gavi are playing? Let me tell you now that I am not constrained from using any of the trade names, because if I don't use the trade names, what happens is at the level of the patient, many pediatricians are confused. Therefore, because I am not constrained from using the trade name, because I am not putting it in its specific platter, therefore, and I will also be openly telling the costs which is available in some of the hospitals, in some of the states, then only the choice will become evident to the pediatrician. Cost benefit ratio, you will get an idea. Now, these are the two questions. These are the two questions I will put it up in the first of the two videos which I am putting today. We will also have to think of, is there a danger of vaccine serotype? In the next video, we will be looking at, is there a danger of vaccine serotype being replaced by a non-vaccine antibiotic resistant serotype infection in vaccinated children? And also, why is the Indian Academy of Pediatrics having a different dosage schedule, advising a different dosage schedule to the WHO regime of 2+1. The IAP is endorsing 3+1 regime for pneumococci. And the natural question is, what is the best dosage regime in this? If you dive deep into all these factors only, you can come to the last but the most important question, which haunts us often. Which among the three pneumococcal vaccines should we choose for our private practice? Finally, the million-dollar question is, which among the three pneumococcal vaccines available in the market should one choose for vaccination in private practice in India? Let me tell you, in this video, I'll be discussing the first two. The next three will come in a couple of days in the second part of this video. Before we embark on this presentation, some background information, not that you are not aware of it. Now, two polysaccharide conjugate vaccines have been in the market since 2010, in the world market actually, the 10-valent PCB10, which is Synflorix, and the 13-valent PCB13 vaccine, which is Prevnar. Now, I do say the trade names because this is not in a platform of IAP or any other organization. Unless I put these things, trade names, I give you the trade names, things don't become very clear to many people. Now, PCB13 and PCB10 are licensed for prevention of invasive disease, pneumonia, and acute otitis media caused by the respective vaccine serotypes in children from 6 weeks to 5 years of age. Remember, note this, from 6 weeks to 5 years of age alone. That is why above 5 years, you don't give it to immunocompetent children. In addition, PCB13 is licensed for the prevention of pneumococcal disease in adults above 50 years. Now, Pneumocil, a new entry of the Serum Institute of India, which was previously called this Serum Institute SIIPL PCV, which is Serum Institute of India Private Limited Pneumococcal Conjugate Vaccine, is now called as Pneumocil, is a pneumococcal polysaccharide conjugate vaccine with 10 valency. Has been pre-qualified by the WHO in December 18, 2019. And the WHO is approved for active immunization against invasive disease, pneumonia, and acute otitis media caused by streptococci till the age of 2 years. Note that it is approved only up to the age of 2 years, while Synflorix and others have been PCB10, PCB13 up to 5 years in normal immunocompetent children, and PCB13 has been approved above for adult immunization as well. From 2020, Gavi will offer countries a choice among the 3 pneumococcal vaccines. One from Pfizer, which is PCB23, one from GSK, which is PCB10 or Synflorix, and the one from Serum Institute, which is the Pneumocil. Now, what is important to note for us is that the DCGI, which is the drugs controller of Government of India, has approved it for active immunization against invasive disease and pneumonia caused by streptococcus in infants from 6 weeks of age in 3 doses, 6, 10, and 14 weeks. What is important for us to note that it has approved for use in 6, 10, and 14 weeks. The WHO says a 2+1 regime, which is 6 plus 14 weeks and 9 months. And most of the studies are done with this regime, which was the WHO has done as far as Pneumocil is concerned. But since DCGI has approved it, pediatricians in India can be happily use it in 6, 10, and 14 weeks also. After having given you some background information, let's take up questions one by one now. Now, the first question which we asked is PCV equally efficacious against pneumonia, otitis media, as in pneumococcal invasive diseases like meningitis or septicemia in children? Therefore, is it effective only in meningitis and septicemia, or is it really effective against diseases like pneumonia, equally effective against pneumonia and otitis? To answer that question, we need to have some discussion about the efficacy of the vaccine. First, we will look at the efficacy of PCB10 and PCB13, which has been there for the last 10 years, and its efficacy is more or less established. PCBs are considered safe and immunogenic in all target groups for vaccination, including immunocompromised individuals. They prevent invasive pneumococcal disease serotypes included in the vaccine types. The efficacy is somewhere near 77 to 95%. But in the various studies, this might quite change. But it is very high, actually, the efficacy. All have the same impact on the carriage of pneumococci. Now, both the WHO and the CDC Pink Book says that, but that's a little controversial statement because of the PCB13 effectiveness on 19A. The carriage, we will come to that later. In a systemic review and meta-analysis from 7 studies, the pooled vaccine efficacy was 80% observed against vaccine type invasive disease and 58% against invasive disease irrespective of serotype. That means what they type is there is some cross serotype protection. Therefore, even if the invasive disease is by a serotype not included in the vaccine, it has some effect, it has some significant effect also. About 58% protection is there. Now, we come to that last statement, PCV10 and PCV13 have comparable efficacy irrespective of vaccine serotypes based on non-inferiority studies with PCV7. Now you must note that PCV7 was the first one which was introduced, and therefore later on when you introduce another vaccine, it is not ethical to compare it with a placebo. Therefore they always compared it with PCV7. And they made a general statement that both PCV10 and PCV13 have comparable vaccine efficacy. And the quotation is from WHO. This is again a rather controversial statement, actually, because many studies have shown PCV13 as an edge. And there is some reason why WHO would like to have at least 2 vaccines in the market. They seem to be siding with the statement that they have almost equal efficacy. Now coming to the new vaccine, which is Pneumococcal, which is now by the Serum Institute, which is often called as 10-valent PCV instead of PCV10. They did a trial. Therefore, this is a relatively new vaccine. Therefore, you don't have 10-year experience as the other 2 previous vaccines. We depend on phase 3 trial done in Gambia. In fact, it is funded by the Gates Foundation. And they found out that even the phase 3 trial, when comparable to PCV10, the lot-to-lot inconsistency, immunological non-inferiority for all 10 serotypes for by both non-inferiority criteria, non-inferior non-interference to all EPI vaccine, acceptable safety and tolerability profile, immunological memory, boosting, etc. They were equivalent. They was non-inferior to PCV10. And further, in an Indian study in phase 3 trial, where they compared it to both PCV13 and PCV10, all the above criteria were more or less met. Therefore, Pneumococcal has also undergone very rigorous studies conducted in both in Gambia and in India. Now coming to the question whether it is equally effective against pneumonia and alveolar pneumonia and other causes of pneumonia. Actually, it is not. If you look at this chart, this is only one of the studies. Probably many studies, there will be quite variation. But generally, it is most effective against invasive diseases, vaccine serotype, invasive pneumococcal disease like meningitis and septicemia. In all pneumococcal IPD, what you mean by means that it also includes serotypes which are not in the vaccine also, slightly less, maybe 60 to 80%. If you look at the alveolar pneumonia, it is around about 30 to 40%. Actually, it is a little on the lower side. Many studies show up to 50%. And all-cause pneumonia, what do you mean by is this not, we don't know the cause. Maybe it is H influenza or even viral pneumonias is about 10%. This is also important to understand. Even in viral pneumonias, pneumococcal vaccination is supposed to decrease the mortality and morbidity. This is because the viral pneumonias later on gets complicated by secondary bacterial infection. And even in COVID, there has been reports in which they have said that patients who are vaccinated with pneumococcal had less mortality. And the least effect it has is on otitis media, which may be around about 10%. But nowadays, some of the vaccines, they claim they have up to 35% effect against otitis media. Therefore, I am just giving you a broad idea. If you look at the efficacy, definitely the pneumonias don't come anywhere near the affecting invasive pneumococcal disease. That means pneumonia in which there is no bacteremia. Therefore, coming to the first question, is PCB equally efficacious against pneumonia, otitis media, and invasive IPD? The answer is no. The effectiveness against pneumonia is less, but its impact because of pneumonia is much higher, because pneumonia is a giant killer and it is 100 times more common than meningitis. Now let's come to the second question. From 2020, Gavi will offer countries a choice among 3 pneumococcal vaccines endorsed by WHO. That means they will give funding to 3 vaccines. That is PCV13, PCV10, and 10-valent PCV. Do they have the same efficacy and impact on pneumococcal disease? Is it justified? Are they equally effective? And do they have the same impact on pneumococcal disease to justify this funding? To find an answer to this question, we will have to have a hard look at each of the PCVs. Now, we will be comparing first between PCV10 and PCV13. Let's forget PCV7 now. Now, if you look at it, the PCV13 has 3 additional serotypes. That is number 3, number 6A, and number 19A. Now, the absence of 19A and 6A as well as serotype 3 in PCV10, we would have to look into what is implications of this. Now, the WHO position paper 2019, as per SAG recommendation, says as far as serotype 19A and 6A, in the settings of a high 19A or 6A offering cross protection burden, PCV13 or other PCVs with 6A and 19A may lead to greater reduction than PCV10. Now, PCV10 is Synflorix, and the 10-valent PCV, which is manufactured by Serum Institute, does contain 6A and 19A. Now, the cross protection from serotypes in PCV10 did not appear to offer the same magnitude of benefit as those observed from using PCV13. Now, all pediatricians but know that this is the position of SAG as well as WHO position paper 2019, which is the latest. Because this is a bone of contention. When Synflorix, people telling that, look, 19A and 6A may not be there in that, but it does offer cross protection. It does, but not to the extent that it is not that efficacious, neither does it have an indirect effect. Now the other therefore, but 19A6A note is present in pneumococcal. Now type 3 is not present both in Synflorix and pneumococcal. But we would like to know what the implications of this is. But the point is that PCV13 induces an immune response on serotype 3, no doubt. But according to studies done in European countries, they say that the type 3 13-valent PCV13 has no effect on serotype invasive pneumococcal disease and carriage. Therefore, though PCV13 contains serotype 3 and produces antibodies against it, it's not supposed to be very effective according to European studies. And as far as PCV10 as well as pneumococcal is concerned, it doesn't contain serotype 3 and therefore has no antibodies also. As it often happens in science, there will be often evidence to the contrary. There are some suggestions of indirect effect. The European Centre for Disease Control and Prevention, ECDC, which must be the counterpart of CDC, has reported in countries using PCV13 in pediatric immunization program, the incidence of serotype 3 disease decreased by 11% among people 65 years and older, compared with an increase of 51% in countries which use PCV10, Synflorix. There's no study with pneumococcal. Remember this, they are not talking of any effect on the pediatric population, but they are telling that it definitely has an effect on adult population where serotype 3 is an invasive disease, but not a very frequent one. But contrary to this, UK epidemiological data up to 2017 indicate that the PCV13 in infants had no direct or indirect effect on serotype 3 invasive disease. Therefore, the drop of serotype 3 in PCV13, which is Pravana, and in PCV10, which is Synflorix, and also in Pneumococcal, is not considered very important. Therefore, it's not a serotype which has much significance according most of the data. Though, as I told you, that in science there will always be some evidence to the contrary. Now let's have a look at the 10-valent PCV vaccine, which is a new entry, which is called the Pneumococcal. Here is the hero. Now, if you look at a hard look at it, it is supposed to have the coverage, IPD coverage, as far as invasive pneumococcal disease serotype coverage is concerned. It is supposed to have 71.7% globally, and in India, it's supposed to have 73% of the serotypes. Well, now let's look at it hard. If you look at it very carefully, it does not have serotype 3 here. But the great thing about it is, unlike PCV10, it has 6A and 19A. But it drops 4 and 18C. 4 and 18C, which are present. It is not there, 4 is not there, and 18C is not there. So this is the critical question. If you drop 4 and 18C, two vaccines which are present even in PCV10 or Synflorix, is it not inferior to Synflorix? Does it not affect its effectiveness? That's the basic question. We will not be discussing serotype 3, which we have already done, because we have said it's not that important. Now the serotype, dropping of serotype 4 and 18C in Pneumococcal is a very crucial factor which you have to look into. Does it not make this inferior to even Synflorix, which is PCV10, which contains 4 and 18C? Definitely it has 6A and 19A, 6C and 19A, which makes it very good. But what about dropping 4 and 18C? Now the justification given is, in most of the studies which are done in South America and even in India, the prevalence of these two strains are very low. For example, in India, 4 is as low as 0% in a study. And the highest you can find out is 1.75% of strain 4 and 18C. Therefore, this is the justification used by put forward why 4 and 18C have been dropped. Science is not that straightforward. This might not be a slide which might be shown in IAP meetings, especially if the Serum Institute is being the speaker. This is a slide which has, this is a publication which I looked for a international journal, the Infectious Disease Microbiology Parasitology. They did a capsular serotype specific invasive disease potential of Streptococcus pneumonia. And they classified it into highly invasive serotypes statistically and significant, highly invasive serotypes but insignificant, less invasive serotypes but insignificant, and less invasive serotypes which are significant. Now, if you look at these are multiple international studies done in this. If you look at highly invasive serotypes statistically, 1 and 4 is there, 4 and 18C is in this study, 4 and 18C is in this study, 4 and 18C is again, and 18C is again in this study, 4 is in this study, 4 and 18C are again in this study, and 4 is again here. And you would find, therefore, the majority of the international studies classify 4 and 18C as a highly invasive serotype which is significant. Therefore, you cannot just brush aside the fact that we have dropped 4 and 18C. Maybe its prevalence in India and South Africa and South American countries are so low that it may not have an impact on the disease. Only time will say. Now this slide gives you an idea about the coverage of the serotypes in each of the 3 vaccines regarding invasive pneumococcal disease serotype and coverage by different PCVs in India. It excludes serotype 3, which they say is none of the vaccines are effective against. But PCV 13 contains it, and there's a little bone of contention there. But if you look at it fairly, the coverage hovers around about 70%. These are all Indian studies. And 2016, you will find here it's about, this is PCV 13, 72. This is Pneumococcal 10 valent PCV, which is 71, and Synflorix is 63. For all along, you will find is hovering around 70, 75. The highest is, of course, marginally superior is Prevenar or PCV 13. And the next is coming is Pneumococcal, and the third is Synflorix. All these differences may not be statistically significant, but what it shows that the Indian new Serum Institute vaccine, or it has the coverage of the serotypes as far as invasive pneumococcal disease in children are concerned, is better than Synflorix because it contains 6A and 19A, and therefore definitely only slightly inferior to PCV 13. Now, many countries which had introduced PCV found an effect not only in the target population, that is between 6 months and 5 years, but also found a reduction of pneumococcal diseases beyond that age, even in elderly. This is because the PCVs have an effect on nasopharyngeal carriage, and therefore it protects not only the children who are vaccinated, but also their contacts, including elderly people in the family. And this is called indirect effect or the herd protection. Now, this is determined by the effect on the carriage. The direct effect is determined by efficacy, effectiveness against the disease. Now, the nasopharyngeal carriage of especially 19A gives an advantage for PCV 13 to have an better indirect effect. Now, as far as invasive diseases like meningitis, bacterial sepsis, and bacterial pneumonia are concerned, an antibody concentration above 0.35 microgram per ml will be sufficient to sufficient for protection. But as far as nasopharyngeal carriage is concerned, it requires a higher concentration, and therefore this nasopharyngeal carriage protection is important for indirect immunity. Therefore, for indirect immunity or herd immunity, you require a higher concentration. Therefore, cross protection against strains will not produce a higher antibody concentration, and hence will not produce herd immunity. This is where PCV 13 scores over PCV 10 as far as 19A is concerned, because 19A is an important pathogen in elderly, and PCV 13 does produce concentration much above this level and has an effect on herd immunity, while Synflorix or PCV 10 does not have it. As far as Pneumococcal is concerned, it does have 19A, and therefore theoretically it should also produce indirect protection. In other words, the PCV coverage drives nasopharyngeal carriage of pneumococcus, which drives the rate of pneumococcal disease. All schedules of PCV administration is effective when administered appropriately, but you must ensure an uptake of about 75% to influence nasopharyngeal carriage in the overall population. Therefore, if you have a coverage more than 75%, the herd immunity kicks in, and the receipt of PCV reduces the risk of severe disease associated with even respiratory viruses that requires hospitalization, suggesting that co-infection with pneumococcus contributes to severity of disease resulting in hospitalization. This is an important slide for all pediatricians. If we must not only give pneumococcal vaccine, and we should aim for an achievement above 95%, 75% coverage at least in the children. This will reduce morbidity and mortality not only under 5 years. children above 5 years, and even reduce adult hospitalization due to respiratory infections. Now, the WHO expert group on vaccine, the strategic advisory group of experts, concluded in a report in February. There is at present insufficient evidence of a difference in the net impact, note the term impact, of the Pfizer and GSK pneumonia vaccines on overall disease burden. And they went on to say, the author of this article in Lancet goes on to say that the serum vaccine promises to be just as effective because it is only a newly introduced vaccine, and its effect we have not, efficacy can be studied. Effect will take some time to study, maybe 2-3 years before we look at the effect. Now, from 2020, Gavi will offer, must have been offering already, a choice among 3 pneumococcal vaccines, one from Pfizer, PCV13, one from GSK, PCV10, and one from Serum, which is 10-valent PCV or Pneumococcal. Now, you might want to after having said that PCV13 has an edge as far as efficacy is concerned because of its superior indirect effect on the nasopharyngeal carriage, etc. How can all the 3 vaccines have the same impact? Now, you must know the definition of these terms. Efficacy means protecting an individual from disease by the vaccine in ideal conditions. Example, when you do a randomized controlled trial. Now, the efficacy of a vaccine might be good, but the effectiveness may not be good. By effectiveness means protecting an individual from disease by the vaccine in real life conditions. For example, the efficacy may be very good when you do a experimental study, but in real field studies, if it is an oral vaccine, for example, the child may spit it out. That might be enough for the effectiveness to go down. Now, the impact of a disease is a reduction of disease and its consequences in real life post-vaccine implementation. Now, if you look at pneumonia, its effect is very much less than in pyogenic meningitis. But pneumonia is at least 100 times as common as pyogenic meningitis, and otitis media is at least 1,000 times as common as pyogenic meningitis. Therefore, what happens is, when you give pneumococcal vaccine, the reduction in the childhood mortality caused by pneumonia may be much higher than the reduction in the childhood mortality caused by its effect on meningitis or invasive disease. Though its effect on invasive pneumococcal disease is much higher. I hope I have made it clear. Now, if you want to look at it, this is the impact. It depends, of course, on effectiveness, the indirect protection like herd immunity, etc. I can just discuss only one of them. The vaccination uptake is a very important thing in impact of the disease. Now, if the vaccination, for example, is a painful one, naturally the impact will be less because patients may not come back for the second dose. Same may happen if it is a very costly vaccination. If it's a very costly vaccination, they may not complete the course. Therefore, though the vaccine PCV13 per se may be much more effective than PCV pneumococcal vaccine, if more and more patients with pneumococcal complete the vaccine course, definitely its impact will be better. I hope this matter is clear to you. One point I would like to drive home is the fact that PCV13 serotypes, especially serotype 3, 19A and 19F, continue to account for nearly a quarter of the invasive pneumococcal disease in US children 4 to 7 years after the PCV13 was introduced. Therefore, and underlying conditions are more common in children with non-PCV13 serotype IPD. An immune evaluation in otherwise healthy children with PCV13 serotype IPD, despite receiving more than 2 doses of PCV13, did not identify an immunodeficiency. What it shows that whenever you get a pneumococcal disease in a children, even in immunocompetent children, don't jump into the conclusion immediately that this is by serotypes not included in the vaccine. Even in immunocompetent children in America, which was a study which was done between of invasive pneumococcal disease between 2014 and 17, which appeared in the pediatrics in as late as 2019, they state that majority of the pneumococcal diseases which occur are in strains, at least 25% of the pneumococcal, invasive pneumococcal disease which occur are due to strains which are present in the vaccine itself. Now, this is understandable because the vaccine does not have 100% efficacy. It's somewhere between 80 to 90%, some maybe just about 90%. Now, why I'm emphasizing this fact is many people, whenever they see a patient with pneumococcal pneumonia or pneumococcal disease, septicemia or meningitis, immediately ask the patient, have you taken the vaccination? And if they have taken PCV10, they immediately tell them, you should have taken PCV13 and that would have protected you. There are 3 strains other than in PCV10. No, that is not the right statement. Many times it is the strains in the vaccine itself which causes the pneumonia, and no effect. I mean, no vaccine is 100% effective. We were trying to find an answer that whether the Gavi, which offers the countries a choice among the 3 pneumococcal vaccines endorsed by the WHO, is it justified? Is it justified? Because do they have the same efficacy and impact on pneumococcal disease? We found out that efficacy might be slightly higher for PCV13, but the impact depends on so many other factors like the cost of the vaccine, regular availability of the vaccine, etc. On in this, Pneumocil and PCV10 might score better, especially Pneumocil. And this other question is PCV10 without its 6A and 19A, which is much more costlier than 10-valent PCV, which is Pneumocil. Is it justified to be recommended? Now you must understand that PCV10 is there for the last 10 years and is effectiveness as well as impact is well proved. 10-valent vaccine, which is Pneumocil, efficacy studies are very good, but we will have to await data for its effectiveness as well as impact. But there's no reason to suspect that it will be anywhere less than vaccine. Therefore, I think the Gavi is fully justified in endorsing all the 3 and funding all the 3 vaccines and leaving it to the individual countries to choose which vaccine they want. With this, we come to the end of the presentation, and I'm Dr. A. Padmanabhan, and I do put some other some videos on this YouTube channel. This is the link to that, my home page. And you can also find some blogs which I have written on birdprocess.com. And this is the link to that particular also. Thank you for listening to me. And I would come back with you in a couple of days with the second part of this video, in which we'll be asking the crucial question, which among the pneumococcal vaccine should be a choice in private practice. Thank you.